Okay, in this video we're going to be going over trigger points and neuromuscular therapy. With the trigger points, there's over 100 that we'll be discussing, and also neuromuscular techniques that we can actually perform on those trigger points. So with trigger points, I'll actually show you the referrals, where the possible referral is, and also the location of the trigger point, also the origin, insertion, and talk about the actions of the trigger points too. But it's very beneficial to actually learn the origin, insertion, action of the muscles in order to actually totally understand for the trigger points. So what we're going to do is we're going to get started locating the trigger points, and I'll explain to you how to actually pronounce the trigger points too. Okay, what we're going to do now is we're going to go after the scaling muscles. There's actually considered three scaling muscles: scaling anterior, scaling medius, and scaling posterior. And with the scaling muscles, technically they're transverse processes of C4 through C6. So the way that you actually want to locate the scalenes is actually elevated. As you can see, the sternocleidomastoid kind of sticks up right here. So you're going to, for the scaling trigger points, you actually want to go underneath the sternocleidomastoid. Make sure it's always the posterior side, make sure it's not the anterior side. And if you have a hard time finding the sternocleidomastoid, lift it up even more. As you can see, it'll stick it up. Also, you can have them contract that region too. So the insertion is the lateral surface of the second rib and also the first rib. So I'm just combining the scaling posterior, medius, and the anterior together. So it will actually start in this region and go down to the first to second rib there. The action is it elevates first, second rib. So with breathing wise, it actually, if somebody has problems breathing, a lot of times they'll actually get really tight in that region. And there's actually a thing called thoracic outlet syndrome, and it can be either the scaling muscles or the pec minor that could actually get impinged and actually shoot pain down the hand all the way to the last two fingers for the referral. But that's for nerve-wise, so the brachial plexus region right here. So with the scaling trigger points, there's technically 6 of them. So you always want to make sure you go really slow. So always watch your reactions when you're actually performing this technique. So just go really slow, and actually communicate a little bit more with them too. So it's not like a Swedish massage where it's nice and relaxing. You're actually here for a purpose to try to get rid of their pain. So the referral for the muscle will actually go down to the thumb and index finger, and it can actually go to the posterior elbow region, also the pec region, and also back of the scapula region. So that's where the technical referral for the muscles is. So you can actually sometimes feel a ropey band right behind the sternocleidomastoid right here. So just go back and forth, and you can even have them kind of tense up their neck too. So try to bring their neck to the shoulder and kind of hold it to resist it. Sometimes you can actually feel that muscle kind of pop out at you then. But it's a very important muscle for breathing wise. So any muscles that attach to the ribs are considered breathing muscles. So make sure you concentrate on those then. So also with breathing problems too, it could be intercostal muscles. The intercostal muscles are in between the ribs. Those can actually get really tight too, so actually mimic breathing problems in those regions. So again, with the scaling muscles, just go really slow, because anything on the neck region, you just got to take a little bit slower. And if you ever feel any kind of a pulse at all, just make sure you do not press on that area then. And if you feel any round lumps, it could be lymph nodes, it could be calcium deposits. Of course, we can't diagnose, you don't know what it is, so just don't push on those regions for the scaling region. So again, for the referral, it will actually go down to the thumb and the index finger, so it should shoot all the way down there if it's actually muscle related. But if it is nerve related, it could be like thoracic outlet syndrome, it could actually go down to the pinky and a little bit of the ring finger. So just make sure you don't mix those two areas up then. Okay, next muscle we're going to go over the Sternocleidomastoid, and it's the mandrium of the sternum and the medial 1/3 of the clavicle. And then it goes up to the mastoid process. So the mastoid process, when you lift up the head like this, right at this little divot here, that's where the actual insertion is. And a lot of times with the muscles, the insertion is the more movable part. So the actions are it actually rotates like this, and also flexes the neck, bringing it up like here. So with the sternocleidomastoid, probably the easiest way to do is you elevate the head so you can locate the sternocleidomastoid and actually pinch this region. So that's a little bit safer way, just because there's, for the anterior neck region, that's an endangered region. So this muscle is actually the main muscle injured in motor vehicle accidents, and is one of the main muscles affected in torticollis. Torticollis is, another name for it is wry neck. So sometimes their head is a little bit tilted and it's hard to actually turn. So some people actually, more likely you've had this problem before, where you wake up in the morning and you can't turn your head. So that muscle actually gets contracted in a position during the night. So again, with the sternocleidomastoid, you have to actually pinch. And there's about 7 different trigger points in that region. So you can actually pinch and actually slide up too, just to locate those. So again, make sure you have some communication with the client during this time. And the referrals, it could actually go down to this region, also the chin, jawline, around the ear, all 3 areas, also the temporal, the frontal region, and on top of the head region. So as you can see, it has many different kind of referrals, and again, it's a big one for headaches. So just make sure you concentrate on this one, because the problem is a lot of times people come in for just a half an hour massage, they have headaches, and you're just concentrating on the back of the neck. You might want to even try to concentrate on the anterior neck a little bit too. And the muscle we're not going to go into depth about is the platysma. That actually covers the whole sternocleidomastoid. So there's technically no trigger points on the platysma here. But again, when you lift it up, just to locate it, and then you can pinch this region, and you can actually slide down and forth. And a good way to actually locate the muscle grain is actually go cross fiber back and forth. So a lot of times it's a little bit easier to feel that way. So if you actually go longitude friction with the muscles, it's a lot harder to actually feel the muscle grain. So make sure you just go cross fiber back and forth. You can go a little bit deeper each time just to locate those areas. Okay. Next muscle is Masseter. This is the main one for chewing. So the origin is a zygomatic arch and the angle of the mandible. So right in here. So with this one, sometimes you want to actually have them kind of clinch your teeth, so you can actually feel that muscle. So that's the main one right here. So there's actually 4 different trigger points in that region. So that can even go to the ear area, and actually just a little bit below, also the sinus region, and also the temporal region. So those are the areas where you can actually refer to, and actually bilateral contraction too. So that's the actual action. Okay? So bilateral contraction, kind of compressing, so actually chewing then. So that's the main one. So this one, you can actually use a glove to actually get into the mouth. That's one form to get into there. And you can even teach the client to actually do it themselves. But otherwise, you can actually just palpate around. And again, just have them kind of tense up. So the muscle grain is like this, goes up and down like this. So you want to go like this, go cross fiber friction, or transverse friction, and that's another name some people call it then. So again, this was a big one for TMJ problems. It can also mimic ear aches too. next muscle is the medial and lateral pterygoid. The medial one is the origin is the medial surface of the pterygoid plate of the sphenoid bone. Insertion is inner surface of the mandible angle. So right in this region, and the actual action is bilateral contraction and closes and protracts the jaw. So it closes and then it can actually protract, so it can actually go forward then. So when you go protraction, it goes forward, and retraction brings it back then. So with this one, it's just a little bit higher than right in this region. So you found the masseter, so it's a little bit deeper than the masseter too. So the masseter is a more superficial muscle right in this region. And again, you can also use a glove to actually go into the mouth. And you can actually go in the mouth and actually kind of give it a little pull. But the thing is with trigger points inside the mouth, they're really tender. So just make sure you have a lot more contact with the client. And of course, use a rubber glove. Make sure it's not latex. Make sure it's not powdered at all. So its superior trigger point is superior to the masseter. And the inferior trigger point is inferior to the superior trigger point. So the masseter trigger point's again right in this region. So the pterygoid is right in this region. So you could actually, the referrals, it could be right around the sinus cavity right here and right in front of the ear. So you can see it can actually mimic ear problems then. So that's for the medial and lateral pterygoid. Zygomaticus. The zygomaticus is a zygomaticus arch and lateral angle of the mouth. So it actually goes to right here to here. And it lifts the corner of the mouth upwards and outwards to smile. So technically that's kind of considered your smiling muscle. So for these, it can actually mimic sinus problems right around in this region here. And there's actually one right over here, right in the corner of the mouth. So those are the location of the trigger points. And then for the Obicularis oculi, the origin is the orbital margin and the fascia of the upper eyelid. So basically it's right around the eye region. That's for the trigger points and location. So you can actually, if you just make sure you ask them and see if they actually have contacts, just make sure you don't go too close to the eye, because especially they can actually dislodge. So you can actually pinch this region up in the eyebrow region. So that can actually refer around here for the pain. And the next one is a Buccinator. So the Buccinator is the maxilla and mandible region, and Ocularis oris. So oris actually means mouth, so that's what that actually means. So it goes right around this region, and it compresses cheek and retracts angle of the mouth. So angle of the mouth, it actually retracts, okay? So it brings it back. So the Buccinator is actually underneath the masseter, right in that region. And the Obicularis oculi and the zygomaticus, one around the eye socket. So again, around the eye socket region, so it's going to refer pain around there. So it's really hard to find the grain of the muscle for these. The Buccinator, sometimes you can actually feel this a little bit, but the other ones, the zygomaticus and the Obicularis oculi, is really hard, so you're going to kind of just go around and ask them what they're actually feeling then for the referral then, okay? Okay, next one we're going to go over the temporalis. So temporal, it actually means temporal bone region, okay? So temporal head, so right around here. So the origin is the lateral surface of the temporal fascia, and the coronoid process of the mandible is the actual insertion. So it actually goes like this then. So you can actually, the action is it closes the jaws and then it elevates and retracts the jaw. So elevation, bring it up, and then retracts, bring the jaw backwards then. So with the temporal region, just make sure you don't push on the actual temporal pulse. So use that as a landmark. So just go a little bit superior to that and try to locate those trigger points then. So the referral for the temporalis, it actually goes right above the eyebrow region, right around here too, and also right around the mouth region. So as you can see, a lot of these actually refer for typical headaches. So that's why you cannot just concentrate just on the back of the neck, even though you've heard so many times that the muscles in the back of the neck are big ones for headaches. Still, if you're not getting any benefit from those regions, actually go to the front of the face to actually locate them then too. So technically, again, with trigger points, our trigger points are actually referral areas. So if you actually treat an area that they're actually having pain, you're in the wrong area 75% of the time, just because with trigger points, they manifest, they actually go in other areas then. So again, just like the typical headache in the neck region, will actually go to the head region for the referral. So that's actually considered an active trigger point, but a latent trigger point is when you can press and then it hurts and then it gives a referral. So they didn't have that pain before until you actually started pushing on that region then, okay? Okay, deltoid region. So there's actually considered 3 deltoids. Some books actually just say it's just 1 deltoid, just right in this region. But there's actually considered anterior deltoid, and then the medial deltoid right here, and then also the posterior deltoid. So the origin is the lateral third of the clavicle. So right in here, so that's where the actual origin for the anterior, and all the insertions for the deltoid actually go down to the deltoid tuberosity. So that's the actual insertion for all 3 deltoids. So that's why some books actually just say it's actually just 1 muscle, but some books separate it and actually say it's 3 muscles then. So, and then also for the medial one, it's actually a acromion process, acromion and lateral spine of the scapula. So it actually starts in this region here. So again, the anterior actually goes down like this. The medial, or some people call it lateral deltoid, starts like this. And then the posterior deltoid, lower lip of the spine of the scapula. So the spine of the scapula, when we flip her over, we'll actually be able to feel, and I'll show you where the spine of the scapula is, right in that region. So the deltoids, the medial deltoid, there's actually 4 trigger points on that region. So it's totally lateral right here. So it actually just refers around that region. And the anterior, there's only 1 trigger point right around here, and it'll just refer around here then, okay? And the posterior, it'll just refer around the posterior region. So you know if it's just totally lateral, more likely it's the medial deltoid. If it's just anterior region, it's going to just be the anterior, and posterior, it's just going to be the posterior deltoid region. So the actions of it actually flexes the humerus, so it actually brings the arm up like this, and also adduction, so the arm close to the body like this, medial rotation like this, abduction to 90 degrees. So abduction, it just brings it straight up like this. So that's for the medial deltoid. That's the only action it does, is just abduction to 90 degrees. But the other actions are for the anterior deltoid. And then for the posterior deltoid, the actions are, it does extension. When we flip her over, I'll show you extension of that. And then also horizontal abduction, so you have the arm out straight, and then you just bring it straight back like this. And also lateral rotation, so it's bringing it back like this then, okay? So again, this is medial rotation, lateral rotation, horizontal adduction, horizontal abduction, adduction, abduction. Okay, so those are some of the actions of that region then. Okay, and some people actually call this the shoulder pad muscle, just because it actually is a little bit bigger in this region then. So you remember in the 80s when people actually wore those jackets with the shoulder pads kind of built up in that region, so that's kind of how it's got its name too, as the shoulder pad muscle. Okay, next one, we're going to go after the subclavius. And some people actually don't even have this muscle. So the typical referral is just right around this region. And then it can actually go down the arm a little bit. So it's basically, the origin is the first rib and cartilage region. And insertion is inferior and lateral aspect of the clavicle. So right and around it here. And the major actions are it elevates the first rib and stabilizes the joint and draws the clavicle down. So it brings the clavicle kind of down then, okay? So with this one, what you have to actually do is find the clavicle region. And you got to kind of hook underneath of it and then kind of palpate around. So again, if you feel any round lumps, anything in these regions, make sure you don't push right on there. But what you're trying to do is trying to find a referral, so it's going to go around here and then also down in this region here. Okay, next one we're going to go after is the Coracobrachialis. And with the Coracobrachialis, what we're going to do here is I'm going to bring out the arm right here, and we're actually going to pinch right in this region here. Okay, for the referral for the Coracobrachialis, it actually goes down to the middle finger. So it'll actually go down all the way to the middle finger for the typical referral, and more on the posterior side of the arm all the way down. Okay, the origin is the coracoid process of the scapula, and the insertion is actually the middle of the medial humerus. So again, it's just this little area right here where you can kind of pinch and you kind of roll over that region. And you can actually have them try to bring it towards, kind of forward like this, so you can actually feel that region, okay? So again, you got to just pinch the Coracobrachialis then. So the Coracobrachialis, again, it's just right in here, but if you elevate the arm, bring it out, you can actually feel that area a little bit easier then. Okay, for the Sternalis, what we're going to actually do is we're going to find the xiphoid process right here, and the sternal notch, and it's basically halfway, and then just half inch off, right in that region. So this is the area where you're going to actually palpate for the trigger point, and it should actually just refer right around here. And if the client doesn't feel comfortable with you pushing down in this region, you can actually double or triple up a towel, place it over there, so you can actually push down in that region. Or you can actually just use their fingers just to actually palpate, so you can actually push down in that region then. So again, some people don't have the Sternalis, and some people don't have the subclavius, but almost everybody again has the Coracobrachialis right in this region. Next one we're going to go over is the biceps. So the biceps brachii, so that's an actual technical term of it, but a lot of people just say biceps. So it's a coracoid process of the scapula and the tubercle of the glenoid fossa of the scapula. So right up in this region. So, and then the actual insertion is the posterior portion of the tuberosity of the radius. So the radius right here, the radius bone, the radial bone, and the ulnar bone. So the easy way to actually remember that is the radial pulse. So the radial pulse is the radial bone, so that you can actually remember those regions then. But this is actually considered anatomical position when the palm is face up. So that's where you locate the biceps brachii then. So the major actions of biceps brachii, the flexion of the arm and forearm, and supinates forearm. So supinate, so this is pronation, so this is supination, okay? So the anatomical position, supination. So inflection of the arm, so it actually brings it up like this, and the forearm too, so it goes like this. So the biceps brachii, it's pretty easy to find the trigger points. What you want to basically do is just actually find the belly of the muscle right here, okay? So there's one on each side. So the typical referral for the biceps is actually, it just goes down a little bit, or it could just go up a little bit. So again, it's right in the center, right here, for the biceps. Next muscle we're going to go over is the brachialis. So again, we went over the Coracobrachialis up here. Next one is the brachialis. So it's basically, for the brachialis, it's right in this region, and so it's underneath the biceps. So the biceps is a more superficial muscle, and the brachialis is just underneath of it. So it actually starts here, goes down to this region here then, okay? So with the brachialis, what you want to basically have them do is actually try to have them flex, okay? Flex, okay? And then you feel the biceps, and then have them relax, and right at the lateral notch right here, that's where you're going to actually locate the trigger points. So the referral for the brachialis should actually go down to the thumb region. So that's a typical referral. So especially us as massage therapists, that's where we're going to get some problems, is right in the thumb region. So again, you're just going to palpate right in there. But it's always a good idea to actually have them flex first, just so you can locate those areas. Next one we're going to go after is the pec minor. So the pec minor, pectoralis minor, that's the name of the muscle, you have to actually basically pinch right here. So you can actually pinch this region to locate it. So the origin is actually second, third, and fourth ribs, and the insertion is a coracoid process, so right up in this region. So again, what you're going to do is you're going to pinch this area, and the major actions of it is actually protraction and also depression of the scapula, so it brings it down then. So those are the major actions. But for the pec minor, for the actual muscle, it's just going to refer just around this area. That's all it's going to do. But again, if it's actually like thoracic outlet syndrome, of course we can't diagnose, but it's actually going to go to the last two fingers here for the referral. So if you're pinching those areas and it's going to the last two fingers, you might be impinging the nerve in that region. So just make sure you back off. And so kind of the rule of thumb with trigger points, neuromuscular therapy, if it tingles more than 5 seconds, or if the pain is actually getting worse or it's not getting better after 10 seconds, might want to back off and just move off a little bit. So technically when you're holding a trigger point, it should start getting better after a few seconds. But if anything longer than that, then you might want to try a different technique or just move it just a little bit. So that's all it takes, is just moving it just a little bit, and then you can actually be a little bit more beneficial then. So I'm going to show you how to access the pec minor. So again, we're going to pinch here, and we're going to go underneath the pec major. So you're going to bring the arm over like this. So they're going to horizontally adduct then. You're just going to hold it then in that region then. So it's kind of a tricky muscle. It is possible to actually access it through the pec major, but if you want to actually get right to the pec minor, that's where you have to actually go underneath that region then. But when you go underneath that region, kind of slide on the anterior ribs, so don't go straight in and hold it. So the axillary region, so that you can actually cut off the circulation. So again, ask them where the referrals are, those kind of sensations, just to be safe then, okay? So again, you can bring it over and hold it And you can even move the arm around a little bit too, just to make sure you got that exact spot then for the pec minor. But again, a lot of people just call it pec minor instead of pectoralis minor. It's just a little bit easier to understand then. Okay, and the next one is the pec major. Pec major, the origin is the medial half of the clavicle and sternum, and also costal cartilage of the ribs 1 through 6. And then the insertion is the lateral ridge of the bicipital groove. So right around here is actual insertion. So the origin is all this region here. So again, it kind of protects the pectoralis minor. So the pectoralis major, it actually is more superficial muscle right in here. So with these, it's a really good idea to ask the client where the actually areola is or nipple region is, just to make sure you're not pushing on that region. So on women, it's a little bit more tender on the breast region. So any adipose, the technical name for fat, it's going to be more likely to bruise in that region when you're actually pushing down then. So there's actually many different trigger points, and most of them are just superior to the nipple region. So you're going to actually locate them like this, and again, if they don't feel comfortable with you palpating this region, you can use their fingers, so you can actually put a towel over that region to access that a little bit easier. And sometimes the towel is a little bit easier just because it's less likely to bruise because there's a little bit more cushion in that region. So the actions, it actually adduction. So adduction, it actually brings it too close to like this. And also horizontal adduction, so it brings it straight over like this. And also medial rotation, so it's like this. And the reason why I have the hand up here is to show medial rotation. It's just because it's a little bit easier to see then. Because otherwise you can just have it like this and just rotate it, but sometimes people get confused with the forearm then. So that's why I just have it flexed a little bit and just perform medial rotation. And then also flexion of the humerus. So you want the arm totally at the side and just bring it straight up like this then, okay? So that's considered flexion right in that region. So again, with the pectoralis major, it can actually refer around the whole chest region. This can actually mimic heart attacks too, but of course if any client is really tight chest that just came on, of course you're going to send them right to the hospital right away just to be safe. So it can actually mimic difference in heart palpitations too. So there's many things that can actually mimic right in here then, okay? So it's kind of hard to feel the muscle grain in a way, but also if you want, you can actually have them kind of resist you, try to push down, and so the muscle kind of sticks up at you a little bit too then when you're trying to locate the pectoralis major. So again, it's a little bit easier for a male to actually locate these, but for females too, it is beneficial, but it's really overlooked for the female population right in here then, okay? So still concentrate on those regions. For the next muscle, we're going to go over the Brachioradialis. So the Brachioradialis is the lateral supracondylar ridge of the humerus. So right up in this region, and then it goes down the styloid process of the radius. So it goes all the way down to here. So the main action is actually flexion of the elbow. It goes like this. So it actually helps with the biceps and also the brachialis. The easy way to actually locate this is actually kind of pinch this region. So the typical referral for the brachioradialis is it actually goes down to the thumb region. So it actually refers all the way down to that area. And this is the big one where us as massage therapists, we're going to have a lot of problems. So make sure you concentrate on that region. And the way you can actually feel it is actually this is actually considered ulnar deviation like this, and then radial deviation like this then, okay? So ulna, radial deviation. So when you go back and forth, sometimes you can actually feel that muscle kind of popping out at you then. So again, you can go cross fiber friction to locate the brachioradialis. But this muscle we're actually going to be using a lot to locate some of the other trigger points and muscles in this region. So again, it's the most lateral muscle in the forearm region. So it's really superficial too. and I'll just show you some of the trigger points for the Adductor Pollicis. Pollicis actually means thumb. So you actually find the index finger like this, and you actually just in the palm region. So there's actually technically 4, or a couple at least, trigger points for the Adductor Pollicis. So Adductor Pollicis, it actually means adduction of the thumb. So it just brings the thumb together like this then, okay? So that typical referral can go around the thumb region. And then also opponus pollicis. Opposition would actually brings the fingers like this. So opposition of the thumb. So when the thumb actually goes like this then. So that's just a little bit inferior to the Adductor Pollicis. So again, pollicis, the technical name, means thumb then. Okay, next muscle we're going to go over is the Pronator's teres. So the Pronator's teres, the origin is the proximal to medial epicondyle of the humerus. So a lot of the flexors, when we get into the flexors of the forearm, start at the right around this region. And most extensors start on the lateral region right here. So a good way to remember it too is the flexors flat, okay, extensors hairy, okay, so extends. So that's why you can remember whether it's extensors or flexors in those areas. So again, for the Pronator's teres, the proximal to medial epicondyle of the humerus, right around here. Then it goes to mid-lateral surface of the radius. So it kind of goes at an angle like this. So of course, the major action of the Pronator's teres, it pronates hands and assists elbow flexion. So it helps a little bit with elbow flexion. So, and then also pronation, palm down, and then when you actually go with the palm down, that's pronation, okay? And supination with the palm up. But again, because it's called Pronator's teres, you'll actually go pronation with the palm down. That's the action. So it's about 1 inch or so, and you have to actually go cross fiber friction a little bit to locate that. But sometimes you can feel this muscle, otherwise you can actually have them try to pronate and supinate and just kind of roll over it. So the Pronator's teres referral would actually just go right around the radial pulse region. And also the Pronator Quadratus. The Pronator Quadratus, the origin for this is the distal 1/4 of the anterior ulna. So again, this is the ulna side, this is the radius side. So it goes like this, and it goes the distal 1/4 of the radius. So it starts here to here. And this is kind of tricky to actually locate the Pronator's Quadratus. You want to actually find the carpal region, go up a couple inches. It's basically right where the radial pulse is, but of course you don't want to push on the radial pulse. And then you just slide a little bit lateral. That's where the typical trigger point is. So again, with both the Pronator Quadratus and the Pronator teres, it should just refer right around this area. Supinator. So again, the muscle right here is a Brachioradialis. That's what we're going to use as a landmark. We're going to pinch that region, and you have to, for the supinator, you have to basically go underneath the Brachioradialis on the anterior side. So this is the flexor side. So the supinator, the major action is assist biceps to supinate hand and forearm. So supination, again, you start the palm down, go up. So that's supination. You have to actually go underneath, right in that region then, for the supinator. It's a really small muscle. So again, the origin is the lateral epicondyle. So again, lateral epicondyle right here. So anatomical position with the palm up, that's anatomical position. So it's a lateral epicondyle, radial, and radial
ligament and ridge of the ulna below the radial notch. So it's right around this region. And then the insertion is lateral surface of the proximal 1/3 of the radius. So it kind of hooks around there. But again, it's deeper than the Brachioradialis, so that's why you have to kind of hook underneath the Brachioradialis to actually locate that. So it's a pretty deep muscle. So this supinator, the referral, should go right down to a little bit of the lateral, right below the thumb. That's where it should typically refer, and it can also refer right around that area too. So those are the two typical referrals for that then. Next one is the palmaris longus. Palmaris longus, the origin, is actually the medial epicondyle of the humerus, and then it goes down to the palm. And the major action is actually flexion of the wrist. So it goes right to the palm area, but it flexes right in there. And palmaris longus, some people don't have that muscle, so just for you to be aware of that one. And for the referral, technically it can go right to the palm region. So it can actually mimic people that have palmar fasciitis, so really tight, sometimes it's hard to open up your fingers. So that's the area that you can actually get the referral from them. So for the palmaris longus, what we're going to be, you remember the pronator's teres was right up here, and the pronator's longus go down a couple inches, 1 inch in. So there's another muscle we'll be getting to pretty soon, but that's the most medial here then, okay? But the palmaris longus, if you get any referral down to the palm region, more likely you're on that muscle then, okay? But again, some people don't have that muscle right there, okay? So some of the fun facts is the Teres elbow is a lateral epicondylitis. So it's, again, this is a lateral epicondyle of the humerus. So it's a lot of tendinitis in that region. So just imagine when they're serving for tennis, that's the area we're going to have to concentrate on. So, and then also for golfers is the medial epicondyle region. So that's the area we're going to be concentrating on for that then, okay? Let's get into Flexor Carpi Radialis. So for the Flexor Carpi Radialis, it's the medial epicondyle. So you remember the medial epicondyle right here, and that's where the origin is, and then the base of the second and third metacarpals. So it kind of explains where it's at. So flexors, again, it starts in this region, and then it goes down to the base of the second and third metacarpals, but it goes over the radius bone. So it kind of goes at an angle right here. So the major action is flexion and abduction of the wrist. So abduction. So abduction is actually goes out like this. Also radial deviation, some people call it. So this is considered ulnar deviation, but since it's Flexor Carpi Radialis, it performs abduction then, okay? So it goes out like that then. So Flexor Carpi Radialis, so what we're going to find here is we're going to make sure you do not never push on the median nerve. It's right directly in the center. Make sure you do not push on there, because for carpal tunnel problems, it's actually going to go down to the first 3 fingers and a little bit of the ring finger. That's a typical referral for actually nerve impingements for a carpal tunnel. So you're going to actually just go off of that muscle then, okay? So you're going to find the medial epicondyle right here, go a couple inches down, inch in or so. But again, not right on the median nerve, but that's where you're going to have to actually locate it. So that's the area for the Flexor Carpi Radialis. And for the Flexor Carpi Radialis, for the referral, it should go right around the radial pulse region. Next muscle, we're going to go to the Flexor Carpi Ulnaris. So again, the medial epicondyle, the humerus, and proximal 2/3 posterior ulna area. So it's a little bit more posterior. So it kind of explains where it's at again. Flexor, so it's a flexor on the flexor flat side. Carpi, it actually goes down to the carpal region. Ulnaris, so it goes more down the ulna bone then, okay? So this is the one that's mostly lateral. So we went over the palmaris longus. So it goes the flexor carpi ulnaris, and then the palmaris longus a little bit more in. And then it goes the flexor carpi radialis. So it goes a little bit more in then, okay? But again, not directly on the median nerve. So the insertion for the flexor carpi ulnaris is a pisiform and the hamate in the base of the fifth metacarpal, so right in this region. So that's where the typical insertion is. So again, the insertion is a more movable part. So the action is a flexion and abduction of the wrist. So it'll actually go like this then, okay? So adduction again, we'll bring it like this. So this is abduction, it's also radial deviation. Then ulnar deviation goes like this then. So you actually want to go the most outside here. So the most outside one over here is the Brachioradialis, where you have to actually kind of pinch. But the flexor carpi ulnaris is about 3 inches down or so, and that should actually go to the right in this region here, okay? So that's where the typical referral is for the flexor carpi ulnaris. Okay, next one is the flexor digitorum. This is more of a superficial muscle. So the origin is the medial epicondyle, the humerus region. And then the sides of the middle phalanges, the digits, 2 through 5. So again, it doesn't go down to the thumb at all. So the major action is a flexion of the digits and all the wrists. So it performs both actions. And with every single kinesiology book, the origin, insertion, actions are going to be a little bit different. So don't get upset if you're hearing it a little bit different than your book actually says then. So with the flexor digitorum, you want to locate the kind of median nerve. Of course, you don't want to push on it. But it's actually here and here. So it's one on each side of the median nerve then, okay? And you can even have them kind of flex their wrist going back and forth, or flex their fingers to actually locate the flexor digitorum. So for the flexor digitorum, it should go to the last 3 fingers for the referral. So that's a typical referral for that then. For lateral rotation of the hip, you bring it out like this. Internal rotation of the hip, bring it in like this. Abduction, leg, bring it out like this. Adduction, bring it like this. Okay, and then flexion of the thigh region, bring it up like this. And extension, bring it totally back then, okay? So those are some of the actions of the hip region. So we're going to concentrate on those. Next muscle we're going to go over is the flexor pollicis longus. So again, pollicis means thumb. So it actually starts up at the anterior base of the middle radius. So it starts up here in the base of the palmar surface of the distal phalanx of the thumb. So it actually goes down to this region. And the major action is actually flexion of the thumb. So with this one, about 2 inches up from the carpal region, that was the pronator's quadratus, and then you just go up another inch, and then you want to kind of rotate it off like this to actually locate the flexor pollicis longus. So the flexor pollicis longus, again, will actually go down to the thumb region for the typical referral, so right in that area. And with the carpal tunnel problems, there's technically 9 tendons, and the median nerve passes through the tunnel from the forearm to the hand. Increased pressure in the tunnel form inflammation of one or many of the tendons, irritating the median nerve. So it can actually be bone impingements or any of these muscles right here. So the major one is the pronator quadratus, so it can actually be impinging right in that area. The rectus abdominis, so your six-pack muscle. So the actual origin is the crest of the pubis and the pubic symphysis. So it actually goes way down to here to the bone, right here. So that's where it actually starts. And the insertion is xiphoid process, right up here. And the 5th, 6th, and 7th rib. So it actually connects over here then, okay? So the major action of the rectus abdominis is the flexion of the trunk. So kind of sitting forward and compresses the contents of the abdominal region. So that's the major actions. So with the rectus abdominis, there are many trigger points, but the trick about this region is you really don't want to push straight down here. You actually want to push more into that region, okay? So I'll just show you some of the trigger points for the rectus abdominis. So the first one is you want to actually find the xiphoid process right here. And just go down a little bit. Okay, and then you can actually push in. So there's a couple here and here. So those can just refer around to this region. So you can actually have them do a little crunch, do a little sit-up to actually feel the rectus abdominis a lot of times. You can actually place your hand there, have them do a little crunch to locate that region. And then also for the lower ones, you want to find the navel. And you just locate it out here. And these typically will go down to the inguinal region for the referral. So that's a typical region for the referral for the rectus abdominis trigger points. So that's why somebody comes in with the groin injuries. It's not always in the groin region. It could be in the rectus abdominis or other muscles we'll be getting into for the typical referral then. So for the lowest one, this one's a little bit tricky. You have to actually kind of push down, push down, push down, push down, push down until you feel the anterior pubis region. And directly not right on the center, because that's more the bladder region, just a little bit lateral and kind of hook underneath of it. But that referral could actually go to the low back region. So just explain to the client what you're actually doing before you actually start palpating this region, just to be safe. And for one that will actually go to the mid-back region, so there's not many of them that will actually go to the other side of the body, but you feel the xiphoid process, like an inch down, inch over. You've got to kind of hook underneath the ribs in this region. So that can actually go to the mid part of the back then, so the typical referral. So for the internal obliques, that's an inguinal ligament iliac crest area. So it's right in this area. That's where the typical origin is. And then insertion, abdominal region, and that's actually the lower 4 ribs. So the action is bilaterally and flexion of the trunk, and unilaterally lateral flexion and rotation to the same side. So kind of rotation of the trunk region. So that's for the internal obliques. And then for the external obliques, that's the external surface of the lower 8 ribs. Okay, so right in here. And the insertion is linea alba in the iliac crest. So it'll actually go down to this region here. And bilaterally, flexion of the trunk, unilaterally, and lateral flexion, and rotation to the same side. So those for that. And for more of the external obliques, you want to feel the rectus abdominis. Again, you can have them do a crunch to actually locate that. And just off of that, you want to kind of push into that, but just make sure you're not pushing into the rectus abdominis. But you really, anything above the navel region, you never want to really push straight down, just because the liver, gallbladder, spleen, all those areas, you just don't want to injure the organs. So that's why it's actually better to go at an angle in the abdominal region. But this is very underused in the massage field, so try to locate these trigger points on here then. So for the transverse abdominis, the origin is the inguinal ligaments, iliac crest, and the lower 6 ribs. And the insertion is abdominal aponeuroses to the linea alba in the iliac crest. So right in this region, so it's kind of transverse. And it actually wraps around the internal organs, and it's actually the deepest abdominal muscle then. So the rectus abdominis is the most superficial abdominal muscle. So again, that's the six-pack region. So for the external obliques, you want to feel the hip, so the iliac crest region, just go up a little bit. You can push into this area, so it can refer around to here. It can actually refer around the inguinal region too. So those are the typical referrals for that. But a lot of times these muscles are kind of lumped together for the trigger points. But that's why use the navel as a landmark too. So for the rectus abdominis, again, there's one just off the navel, just a little bit below too, for the rectus abdominis. And there's also, you remember, there's one right above the pubis symphysis, okay? So that one will actually refer to the low back region. So again, a lot of people have low back problems, so you might want to try that one out if they're not getting any benefit from massaging the back then. Okay, for the Psoas Major, this is a huge one for low back problems. So Psoas Major, this is one of the deeper forms of massage. So it's the anterior surface of the transverse process and sides of the bodies and discs of the lumbar vertebrae. So it's actually really deep. You have to actually go underneath the colon to actually locate this one. And the insertion is the lesser trochanter of the femur. So it'll actually go down to this area. So the major actions is it flexes the thigh, so it brings it up, and laterally flexes hip. And unilaterally assists lateral flexion of the spine, so it helps out with the spine region too. So I'll show you how to locate that. So you always want to find the navel region, go out, make sure it's not on the rectus abdominis. Again, you can have them do a little crunch. So with this one, what you're basically going to do is actually push straight down right here. And if you ever feel a pulse, of course, move it a little bit, or if you feel any round lumps, make sure you don't push on that area either. So you're going to have them take a deep breath in, take a deep breath, okay, a deep breath out. And you just sink your hands a little bit when they breathe out. And then you can do this many times to locate this. Okay, breathe in, breathe out. And sometimes people actually use 2 hands to actually stabilize it a little bit easier. And one more time. And once you're deep enough, what you're actually going to do is you're going to kind of rotate, kind of go underneath the colon then. So you can actually lift up the knee a little bit in order to feel that muscle a little bit better. You can actually have them try to do a little sit-up to just make sure you can feel that. But again, this is one of the deepest techniques for massage, this psoas region. So there's many trigger points for this. In the psoas, it can actually go to the lower back, like the quadratus lumborum when we get to that muscle. And it can actually go up a little bit for the referral, and actually down into the inguinal area. So those are typical referrals for the Psoas Major. In the iliacus, a lot of people incorporate those 2 muscles together, so they call it the iliopsoas group. But iliacus by itself is the superior 2/3 of the iliac fossa in the iliac crest region, and lesser trochanter of the femur. So it actually goes down to this region. So it's on the anterior part of the pubis. It also flexes the thigh, bilaterally flexes hip, unilaterally assists lateral flexion of the spine, and assists in abduction and lateral rotation of the hip. Okay, let's go over the quadricep muscles. A lot of people don't know there's actually 4 of them. They just think it's actually just one muscle there, quads. But the first one we're going to go over is the rectus femoris, or some people say femoris. So it starts in the origin is the anterior inferior iliac spine. So right down here. Then it will actually go down to the tuberosity of the tibia. So again, where the insertion is, that's a lot of times where the action is in the muscle. So the major action extends the knee. So when the foot goes straight up like this, that's extension in the knee. So for the rectus femoris, you have to feel the patella, again the kneecap, go up about 2 to 3 inches, and it's right in the center there. And again, if you can't feel it, have them hold down their foot, have them try to lift up their foot, so you can kind of locate that region, and then have them relax, so you can palpate that trigger point. And for the referral, it can technically go down right to the patella then, okay? So the next one, we're going to find the ASIS, anterior superior iliac spine region, go down about a couple inches, and that one, again, if you can't feel it, go cross fiber friction a little bit, and that one can go to the anterior part of the knee for the referral. Next one is the vastus intermedius. So the vastus intermedius, what you want to basically do for that one, hold down the foot, have them try to lift it up, and you want to go underneath the rectus femoris and have them relax. You can locate that right there. So you're going to kind of hook underneath it there, and that's the typical trigger point for that region. So again, with trigger points are kind of tricky in a way. If you're just a little bit off, you're not going to get that total referral. So that's why you can just slide a little bit back and forth. And for the typical referral, we'll actually just go down a little bit on the anterior portion. So also with the action, it extends the knee. And then the vastus lateralis, there are many of them. So a good way to locate this one, you can be on that side, and you can just kind of rotate it up like this. And this band right here is actually called an IT band, iliotibial band right here, okay? So you got to kind of go cross fiber friction, especially runners, and they actually call it runner's knee, when the hip kind of externally rotates out like this. So it gets really tight in that region. You want to feel the patella, and there's 2 trigger points here and here. You can feel kind of a tight band, and a lot of these around here will actually refer around the lateral side of the knee. And then there's also ones halfway up. There's like 3 of them, but again, make sure you find the IT band. Make sure you don't push on the IT band, and you can locate those regions here. There's also ones a little bit higher up in here too, so we'll actually refer around here for the typical referral. So again, a good idea. A lot of people do not like to actually just hold those trigger points, so that's why you can go one layer a little bit deeper, but again, slower the better for locating those tender areas. And you can usually feel a little bit difference in the muscle tissue to kind of locate those areas then. Vastus medialis. So you're going to externally rotate a little bit just to locate that. So again, the rectus femoris, you can use that as a landmark for these muscles here. So these will typically refer around the medial side of the knee. So the easy way to remember that is the rectus femoris is directly center, so it'll go the anterior part of the knee. Vastus lateralis, more the lateral side of the knee. And vastus medialis will go to the medial side of the knee then, okay? So you want to feel the patella and just go up a few inches. That's one trigger point there. And go up a few more inches, and that's another one. So technically, just don't go up higher than half, and then that's other muscles we're going to be getting into in that region then, okay? So again, vastus medialis, so medial side, vastus lateralis, lateral, rectus femoris. Rectus actually means straight, that's the meaning of that. And vastus intermedius, so that's the deepest quad, so it's underneath the rectus femoris then, okay? So that's what the quad's in. So the pectineus, you're going to externally rotate, flex the knee. So the pectineus is a superior ramus of anterior pubis. So it's way up in here. So that's the actual origin. And then insertion is between lesser trochanter and the linea aspera of the posterior femur. So it just goes down a little bit is basically. And this is a big one for groin injuries, so you might have to concentrate on this. But the problem in this region is the femoral pulse. So you want to make sure that if you feel any pulse in this region, make sure you do not push on it. And also there's lymph nodes, a lot of lymph nodes in this region. So just if you feel anything round or lumpy, make sure you don't push on that region then, okay? So basically, the medial side, we'll get to this, the gracilis, and then the hip here, okay, ASIS, anterior superior iliac spine, halfway, that's where the pectineus is. But a lot of times when you externally rotate the knee like this, it's a little bit easier to actually locate the trigger point then, okay? So right at the femoral triangle, some people call it too. So just go down like a half an inch to inch, and that's where the typical referral is just going to be all around that area. So that's a typical referral for the pectineus. And some people even say that the Psoas Major, iliacus, and the pectineus kind of intertwine with each other. So those are three muscles you want to concentrate on for posture. Okay, next one we're going to go after is the adductor brevis. So the adductor brevis is the origin, is the outer surface, the inferior ramus of the pubis. So, and then the insertion is the proximal 1/2 of the linea aspera of the lesser trochanter, the posterior femur. So the pectineus is the upper one right in the groin region. The adductor brevis is a little bit lower, and adductor longus, we'll get to that one too. But the pectineus here, just like a half an inch down is the trigger point to refer around that area. Inch down from there is the adductor brevis, and that should just go up to the hip region for the referral. And then the adductor longus, an inch down from there. And then the adductor longus should actually go down to the knee region. So all those three, so again, pectineus, adductor brevis, and adductor longus for those three areas. So for, just remember, brevis is more short and stout, longus, of course, a little bit longer. So that's where you can remember those. For the longus, the origin is the crest of the pubis, and then the insertion is the medial half of the medial lip of the linea aspera. So it actually goes down a little bit farther, of course, than the adductor brevis. Then the adductor longus, again, is just the third one in this region, pectineus, brevis, longus. Okay, next one we're going to find is the gracilis. Okay, so the gracilis is the inferior 1/2 of the pubis symphysis. So right at the pubis bone, that's where it actually starts. And then it goes down to, the insertion goes down to the medial surface of the tibia, inferior to the medial tibial condyle. So it goes all the way down to this region. And this one is kind of easy, but it's a really thin and small muscle, but it's the most medial muscle that runs straight down then, okay? So you got to go across fiber friction in order to locate the gracilis. So the gracilis, like three different trigger points in there, and we'll just refer around that region then, okay? So again, it's lower than the adductor brevis, adductor longus, pectineus region, so it's lower. So go about halfway and just go a little bit cross fiber to actually locate those regions then. So the major actions of the gracilis are adducts, thigh, flexion, and medial rotation of the knee. So the adductors, of course, adductor brevis, adductor longus, the actions are adduction and flexion and medial rotation of the thigh. The serratorius. Serratorius is actually the longest muscle in the body, and it actually starts at the anterior superior iliac spine, ASIS, or as is, some people call it. So it starts there, and it goes proximal to medial surface of the tibia. So it kind of crosses over. So again, it's the longest muscle. And the actions is it flexes, laterally rotates, and abducts thigh, and assists with flexion and medial rotation of the knee. With the knee, you have to brace the quad region and just go back and forth. So this is actually lateral rotation of the knee. This is internal rotation of the knee. It's really hard to actually perform it for the client themselves, but you have to brace the quad area and move the foot one direction and another direction to actually show that action then. Okay, so for the serratorius, you find the ASIS, anterior superior iliac spine, and it basically 1, 2, 3, 4, 5, 6. So it actually, that band all the way down in the trigger points, and it'll just refer around those areas where you're palpating them. So again, it's kind of hard to find the serratorius to actually feel it, so that's why you have to kind of visually do some landmarks. So that's why it's a big idea to have some landmarks with the trigger points so you can actually locate these regions on. With the tibialis anterior, it actually starts at the lateral condyle and the proximal 1/2 of the tibia. So it starts up right in this region here, and it goes to the medial and plantar surface of the medial cubiform in the base of the first metatarsal. So it actually kind of crosses over, but in the lower third down here, then it starts crossing over right here to the arch region. So a good way to actually locate the tibialis anterior is actually have them try to lift up their foot, okay, and try to dorsiflexion, there you go, so it actually sticks up, so you can actually feel, okay, and so you can actually feel the trigger points. So there's actually 2 trigger points for the tibialis anterior, or some people call it anterior tibialis, so there's 2 different ways. So the major actions of that is actually dorsiflexion, so it brings it up like this, and also inversion of the ankle. So inversion, bringing it in. This is eversion, this is plantar flexion, but the tibialis anterior, it does dorsiflexion and inversion like this. And this is a big one for pes planus, that's actually flat feet. So there's a weakness in that muscle, so it actually kind of drops the arch. Or there's also pes clavis, it actually is too high of an arch. So people can actually have too high of an arch too. So the tibialis anterior would be too tight then. So then you would want to actually do a lot of stretching. So when you do a lot of stretching, is actually more plantar flexion and also eversion, bringing it out like this to actually stretch that area out then. But this is also a really good one to concentrate on for shin splints. And it could be extensor hallucis longus. Hallucis is actually the big toe. So that's the technical name of the big toe, is a hallucis. Or it could be the extensor digitorum longus, we'll get into that, and also tibialis posterior, tibialis anterior. So those are regions for shin splints, but a lot of people concentrate more on the tibialis anterior region for those areas. So the next one is extensor digitorum longus. So it kind of explains where it's at. So extensors, so this is extensor side. Digitorum goes down to the digits. So again, these are called the digits too. So the fingers are called the digits, also the toes are called the digits. And then longus, so it's long then, okay? So what you want to basically do with that is actually find the tibialis anterior, and it's just a little bit lateral, but not all the way lateral. So the one that's totally lateral is the pronator longus. That's the one we'll get to in a little bit. So the pronator longus, you might want to feel that band. It's kind of a ropey band. It goes the tibialis anterior, and then it goes the extensor digitorum longus, and then the pronator longus. So there's actually 2 trigger points for the extensor digitorum, and that will actually just go to the top of the foot region. And for the extensor hallucis longus, that will actually go to the top of the hallucis area then, okay? So for the extensor hallucis, that actually starts in the middle 2 quarters of anterior fibula. So the one that actually sticks out the most, that's the tibia. So you can use that as a landmark. So, and then insertion is the base of the distal phalanx of the great toe. So some people call it that too, the great toe. And basically the actions are extension of the great toe and dorsiflexion again like this, and inversion of the ankle like this. So So the referral, again, on top of the hallucis or great toe. But the tibialis anterior, it will actually go to the top of the big toe too. And it can also go to the ankle region too. So that's sort of the typical referral for the tibialis anterior then.